Hi, I'm Kristen Klim and I'm recording the case connections for Unit 2. I'm going to start with case number 3. A 5-year-old boy is brought to the pediatrician's office for an annual visit. The mother reports he's been a sickly infant and often appears drowsy. She also has concerns over her son's persistent thirst and frequent urination. The blood samples are taken for insulin measurements at time 0 and an hour after the glucose loading test. The results were given in a chart and illustrated as such. The patient's baseline serum insulin level is 0.8 millunits per liter, when the control or the normal serum insulin level for a patient at baseline is anywhere around 6 plus or minus 2. We are also given the serum insulin levels for after the glucose load was given. So the patient's serum insulin level after 1 hour after the glucose load was given is 5, whereas the control or the normal serum insulin level 1 hour after the glucose load is 40 plus or minus 11 millunits per liter. So the question is, what is the information likely to suggest about the underlying biochemical basis for the patient's symptoms? Just to summarize, the patient's symptoms are that he's easily fatigued, he's experiencing polydipsia, which is being persistently thirsty, and he has polyuria, which is increased urination. So I came up with a differential diagnosis based on these symptoms. I came up with diabetes mellitus, hypercalcemia, and hypokalemia. But with the given lab values showing the patient's baseline sample is a lot lower than it should be, and even after the 1 hour glucose reading is still significantly low, we can eliminate a few options, leading us to the diagnosis of insulin-dependent diabetes mellitus, which is also known as type 1 diabetes and is also known as juvenile diabetes. This, in fact, is when the pancreas is not producing enough insulin. And insulin helps move sugar out of the blood. So with this, we can predict the blood sugar to be increased. But in order to find out more information, we would in fact have to take a fasting blood glucose test. This would require the patient to fast for at least 8 hours before the test to be accurate. If this is what we expect, the patient's glucose level would be greater than the normal range. The normal range for a patient that's fasting is around 100, so we'd expect it to be greater than that. We'd also like to receive more family history. This could tell us a lot about the diabetes in general, but we would like to find out if anyone in the family has had any history of diabetes or any issues with blood glucose either. We also probably would like to get an A1C test that's going to check the average amount of sugar in the blood after about 2 to 3 months. So those are some key elements that would lead us to more information. The next part of this prompt is to list 2 regulatory enzymes that are likely to be active in this patient's hyperglycemic condition. We would expect to see glyconeogenic enzymes such as fructose 1,6-biophosphate, which helps turn fructose 1,6-phosphate to fructose 6-phosphate. We'd also probably see glucose 6-phosphatase, which helps turn glucose 6-phosphate into glucose. So the next case that I chose to answer is case number 4. A previously healthy 2-month-old female presents with jittery spells several hours after breastfeeding. Her mother reports she has not given the baby anything to eat other than breast milk since birth. The baby has only recently been sleeping for more than 2 hours between feedings, and that's when the mother reports these symptoms started. Laboratory results are consistent with hypoglycemia, which is low blood glucose, but are otherwise unremarkable. Epinephrine is administered and there is no increase in blood glucose, but there's an increase in blood lactate. Physical exam reveals a liver edge 4 centimeters below the right costal margin. Percussion of the right chest and abdomen confirms hepatomegaly, which is an enlarged liver. Blood glucose levels increase after breastfeeding, but she cannot maintain blood glucose levels within normal range during fasting. So based on this information, which of the following is the most likely diagnosis of this patient? So from here, we were given 4 options. Option A, hereditary fructose intolerance. Option B, galactosemia. Option C, glycogen storage disease. And option D, glucose 6-phosphate dehydrogenase deficiency. So let's start with option A, hereditary fructose intolerance. Some common symptoms of this disease is convulsions, jaundice, nausea, vomiting, gas, abdominal pain, and chronic fatigue. So with our patient falls into one of those symptoms, the convulsions. The jittery spells that the mom reported could possibly be leading to a seizure, and that would be convulsions. So in fact, she could be seeing convulsions, and we're going to keep that symptom part of our list, and that's why we considered hereditary fructose intolerance. But because the patient's missing the other symptoms, we're going to go ahead and cancel out this option. So on to option B, galactosemia. Again, consistent with the patient, common symptoms of galactosemia are convulsions and lethargy. The other two symptoms of galactosemia that are common are loss of appetite and vomiting. Since those are not seen in our patients, and those are common big symptoms with this disease, we're going to go ahead and delete that option as well. Let's skip down to option D, glucose 6-phosphate dehydrogenase deficiency. So the only symptom that aligns with this deficiency in our patient here is having fatigue. The other common symptoms of this deficiency are pale appearance, headache, sudden rise in temperature, tachycardia, shortness of breath, dark urine, and jaundice. Since the patient that we're seeing is lacking most of these symptoms, we can go ahead and eliminate this option. Let's go back to option C, glycogen storage disease, which is the inability to use glycogen. So as we see with our patients, with our patient in their clinical manifestations, they have a low blood sugar level, which is a clinical manifestation of glycogen storage disease. This low blood sugar can lead to seizures, which in fact could be what the mom is seeing. So that would explain that. The next common symptom of glycogen storage disease would be high level of lactate. This happens when the body is enabled to convert glucose 6-phosphate to glucose, resulting in an abnormal pathway through glycolysis, leading to an increased production of pyruvate, which is then converted to lactate. And so how this happens is the lactic acid is then building up in the kidneys and liver, and that in fact can lead to hepatomegaly, which the patient does have, and is also a common clinical manifestation of glycogen storage disease. Since our patient has all of these clinical manifestations that are consistent with glycogen storage disease, we can go ahead and assume that this is the most likely diagnosis for this patient.